السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم بكل خير. We would like to welcome you in the second session, and this session will include 4 presenters. The first speaker will be Faisal Saoud Al-Hadeithi. He's a medical intern from King Khalid University, and he will talk about functional outcomes of total knee arthroplasty and the effect of obesity in Abha, Saudi Arabia. Please, Faisal, the floor is yours.
Assalamu alaikum. Good morning, everyone. I'm really happy to be here. I'm Faisal, and today I'll be talking about functional outcomes of total knee arthroplasty and effective obesity in Saudi Arabia. Let me start by quoting an editorial that was published in 1994 by the title Knee Replacement Therapy in Saudi Arabia, Present and Future. And I quote, "There are too many differences between population regarding the disease pattern itself, the patellofemoral compartment being the main problem, the habit of daily life, squatting, kneeling, and cross-leg sitting, patient expectation and cooperation. In conclude, the result should be the same on the basis of these and other differences. It's justified to suppose that the results in Saudi Arabia are less favorable than in Western countries. Unfortunately, there are no good long-term follow-up studies published to confirm or reject this suggestion." So, a brief introduction. Osteoarthritis and rheumatoid arthritis are the underlying reason of majority of total knee arthroplasties. Total knee arthroplasty is one of the most commonly performed orthopedic surgeries worldwide. Treatment of knee osteoarthritis is challenging, with knee arthroplasty is considered to be an effective treatment and a definitive management for an advanced stage of the disease, though which is responsible for large health costs. So one of the rationale or reason behind this research was because of the effectiveness of treatment itself. Research has shown that total knee arthroplasty has surpassed coronary artery bypass procedures or renal transplantation in effectiveness. So it's very important as physician to confirm whether your procedure is applicable to your own population. Aim and objective. The current study aims to assess the functional outcomes of primary total knee arthroplasty in Abha, and also to identify the effect of obesity and the outcomes of primary total knee arthroplasty. Method and material. A retrospective cohort was conducted targeting all patients who underwent total knee arthroplasty in Abha from July of 2018 to November of 2021 from orthopedic department at Asir Central Hospital and Khamis General Hospital. After undergoing total knee arthroplasty, patient would be asked to participate in the study. Patient who agreed to participate would be given an informed consent to be signed. After that, all participants received a web-based questionnaire to assess daily function. The questionnaire was constructed by the research based on the comprehensive literature review of all relevant articles and consulting expert in the study settings. We used Oxford Knee Score, and it's important to mention that Oxford Knee Score was made and validated to assess knee function after total knee arthroplasty. The questionnaire includes patient demographic data, employment status, medical history, smoking habits, and body mass index based on weight and height reported values. Second part covered total knee arthroplasty relevant data, including slide, post-surgical complication, adherence to post-surgical physiotherapy. Functional outcomes of total knee arthroplasty was assessed based on the Oxford Knee Score and also from pre-existing medical record. After taking the consent from participant, Oxford Knee Score consisted of 12 questions, each question scored from 0 to 4, with 0 being the worst outcome and 4 being the best outcome. The scores are then summed to proceed an overall score running from 0, which is the worst possible outcome, to 48, which is the best outcome. All completed questionnaires were reviewed for missing data and then included in the study. Result: a total of 120 patients undergone total knee arthroplasty were included. Patient age ranged from 40 to 90 years, with the mean age of 64.8 plus or minus 12 years. Exact of 85 patients were females, and exact of 30%, which represent 25%, experienced some kind of post-surgical complication. Most commonly is the wound infection. Exact of 89.2 of the patient reported that they could not kneel down and get up again afterward easily. 81.7% experienced mild to severe pain in their knee. 79.2 could not walk down a flight of stairs. The overall Oxford knee score for the study for these patients ranged from 5 to 48 with a mean score of 29.5. Conclusion, the current study showed the functional outcomes among patients undergone total knee arthroplasty was not satisfactory, with no significant role of obesity on the reported functional outcomes. This is total knee arthroplasty among our study patients in ABHA, showing the post-surgical complication. 30 patients reported that they did have some kind of post-surgical, post-op complication, with wound infection being the most experienced complication. After that, joint stiffness, joint pain, thromboembolism, and other. Post-surgical adherence to physiotherapy, 95% have complied with physiotherapy after the procedure, and 6 patients denied. This is the overall Oxford knee score among patients undergone total knee arthroplasty in ABHA. Thank you, and I would like to end my talk by quoting a research that was published in 2007 by the title of Predicting Total Knee Arthroplasty Outcomes that said, and I quote, "Cultural differences in terms of lifestyle and the criteria by which patients determine their level of pain and functional outcome may also play a role in patient-reported health status. A further cross-cultural population study should examine these factors," and that's what we did right here in this study. Thank you.
Thank you very much, Faisal, for this good presentation. Now the floor open for the questions.
Thank you, Faisal, for this excellent presentation. Can you just elaborate more regarding your study design? Can you explain it to us further?
Yes, we recruited patients that underwent total knee arthroplasty, and our timeline was those who had it from July of 2018 to November of 2021. Patients who accepted the study were informed about the aims, objectives, and what we want to do with this study, and then we give them the Oxford knee score, which was a 12-item questionnaire that assess their daily function. After that, all data were corrected, validated, and entered for analysis, for statistical analysis.
Simple again, our objective is to enhance the research. Your ultimate objective is to publish this article in a reputable journal or whatever it is. Now, I have 2 comments. Number one, it is a retrospective cohort study, as far as I understand.
Yes.
It is from records. So, number one, why you include about 12 authors or 10 authors? What is the rule? Usually in any publication, there is a statement regarding the role of its investigator. This is number one. Number two, you jump to conclusion that there is no rule of obesity there.
Yes.
But your table isn't clear regarding this issue. So you need to elaborate more into issues. Why you include too many investigators in this work, number one. Number two, how you reach your conclusion that obesity is not a significant role in total knee arthroplasty.
Yes, regarding the objective portion of our study, it has been reported under incidents where surgeon has opted for non-obese patients when performing total knee arthroplasty based on the notion that obese patients were more likely to have post-op complication and less than favorable result. After literature review, the research was conflicted. We have on the one side surgeon that stated obesity have a significant role in post-op complication, and we have surgeon and researcher that said obesity did not play a significant role in post-op complication. So when denying patient access to healthcare services based upon a non-concrete evidence or a notion that these patients may have more post-op complication, when the research is not definitive about it, it's not in favor of the patient, to be honest. We did include اللي هو obese, our portion of obese studies, but unfortunately I didn't add it in the slide. It's there in our research. Obesity did not play a significant role in post-op complication. And regarding the incidence of denying patient, there was a poll done in 2011 published by The Guardian, where 1 of every 4 surgeons said that they will not do a procedure if the patient is obese or smoking, especially if the procedure is funded through a public institution like the National Health Services. And their notion or rationale was because they will have more post-op complication, and as we discussed, the research, the literature is not definitive about this matter. Thank you.
Dr. Ali, please.
Thank you very much, Faisal. Very, very interesting, well-presented poster or work. So, and by the way, this project is one of the International Summer Training Program production. It was presented as a proposal last year, and I'm so glad that they are presenting the preliminary data. And as Professor Mahfoud said, you still need more work before you publish and share your data with others, because the study conclusions are always very informative for clinicians, for researchers who are coming after you. I have just a very brief comment about the style of the presentation. The presentation is totally different than writing paper. So one of the rules of PowerPoint presentations, there are no sentences, there's no period. It's bullet points. So you have to make it more summarized instead of bringing text. It's very, very painful for the audience to follow through the long paragraphs. The other question is the sample. I understood that it's convenient sampling, right?
Yes.
There's no randomness at all.
No, it's convenient based on the patient willing. Is he willing to partake in our research or not? So it's a convenient sampling.
Okay, thank you very much.
Any more questions? If no question, we would like to thank you again, Faisal, for this good presentation and wish you all the best. Thank you.
Please join me to welcome the second presenter, Al-Shayma Ali Al-Asim. She is last year medical student at King Khalid University. She will present a research entitled Disseminated Pulmonary Mycosis Caused by Candida tropicalis in an 11-year-old male patient with chronic granulomatosis disease.
Assalamu alaikum wa rahmatullah. Assalamu alaikum wa rahmatullah. Good morning, everyone. I hope everyone is doing very well. I am Al-Shayma Al-Asim. I am a final year medical student at King Khalid University, and it's my honor to be here today. And before we start, I just want to give a big thank you for all the members of the Club of Medicine and Creativity, and a special thank to King Khalid University, responsible for organizing today. I will be presenting our case study titled with Disseminated Pulmonary Mycosis Caused by Candida tropicalis in an 11-year-old male patient with chronic granulomatous disease. Chronic granulomatous disease, a rare autosomal recessive primary immunodeficiency disease. The immunodeficiency status arises from phagocyte dysfunction. The defect in this patient is in neutrophil NAD-PH oxidase enzyme. There is a defense system in our neutrophils called NAD-PH, called first test. The first step in the system is NAD-PH oxidase complex activation. It will confer oxygen molecule to a superoxidized radical to kill the bacteria and break down the bacteria. So what happens if the patient is missing this enzyme? They will develop a chronic granulomatous disease. And we must know that this patient is vulnerable to catalase positive bacteria. So if the patients come with recurrent catalase positive bacteria, such as Staph aureus or Pseudomonas or Salmonella or E. coli and Klebsiella, and fungal infection like Aspergillus or Candida, you should start thinking of chronic granulomatous disease. Recurrent pulmonary infection are the most common clinical manifestation of chronic granulomatous disease in children. And this investigation aims to report a rare chronic granulomatous disease case in an 11-year-old pre-adolescent boy with a complicated Candida pneumonia. So our patient was an 11-year-old boy presented with a fever, cough, and dizziness for 2 weeks. Cough was wet, no variation between the day and night. Fever was high grade, partially response to antibiotic, night sweat, and weight loss. No audible breath sound or chest pain. He lost around 5 kilograms since his illness began, with a poor appetite. There was no history of contact with tuberculosis infection patient, no vomiting or diarrhea or skin rash, no joint pain or limitation in the movement. So all the systems were normal except the respiratory. There was a cough and increase of force of breathing and decrease exercise intolerance. For the ENT, no ear or eye pain or drainage, no recurrent sinus infection. 1.5 months before the current illness, the patient was admitted to a local hospital with left neck lymphadenitis and underwent surgical drainage. The bacterial culture of the drained pus grew, MRSA, and received 10 days of vancomycin and clindamycin. He was sent home in a good condition. For the birth history, he was full-term birth, no neonate intensive care unit admission, no cord separation delay. His older sister had complicated pneumonia, died at age of 16, 5 years ago, no similar history in the family, and no previous surgeries. Immunization up to date, lives with parents and 4 other healthy siblings. Upon assessing the patient examination, he was alert. Lungs examination showed coarse inspiration crickles, no wheezing, normal work breathing, on oxygen via nasal cannula. Left neck enlarged lymph node with healed scar, no rash, bruises, or lesion, no clumping. For the heart and the abdomen were unremarkable. Our patient was febrile with a temperature of 39, respiratory rate was 20 per minute. He was tachycardic, blood pressure was 110 over 16, oxygen saturation was 85 on 4 liter via nasal cannula. His weight was reported as 20.2, his height was 1 meters and 29, body mass index calculated to be 12%. That means it's considered as underweight. So now I will review his important lab. 28,000 white blood cells, 84% were neutrophils, 11 for lymphocyte, hemoglobin 9.5, platelets count was 550,000. All the results of biochemical tests were normal. ESR was 110, and chest X-ray showed bilateral diffuse airspace disease. For the chest, CT scan showed patchy alveolar opacification. It was a very complicated case, and the challenge we faced where we did not reach the diagnosis easily. The patient was started on aggressive broad-spectrum antibiotic, cover gram-positive, gram-negative, MSRA, and hospital-acquired infections. After 5 days of the therapy, the fever continued with worsening chest X-ray finding and more oxygen requirement. He was on 2 liters of oxygen, and it became 5 liters of oxygen. So the infectious team decided to start anti-TB empirically, even with negative acid-fast bacilli and tuberculous PCR. Again, no response to anti-tuberculous treatment. So we thought about the fungal infection and primary immunodeficiency. We do a bronchoscopy and primary immunodeficiency workup. IV amphotericin B was started empirically, as well as IV steroid. So we go to the fungal, then we did a fungal smear. The result was demonstration of the yeast in the smear made from the sputum and the appearance of pseudohyphae and budding yeast cells. This detects the indication of fungal culture, and Candida tropicalis were isolated from the sputum culture. Going back to bronchoscopy, the sample from bronchoscopy was showed red and cloudy and was negative for gram stain and culture. Bacterial and acid-fast bacilli were normal. Fungal culture showed Candida tropicalis and Aspergillus. Viral panel showed negative. Cytopathology showed no malignant cells. So, last of our discussion arises at failure of IV antibiotic, negative bacterial and mycobacterium workup, suspected primary immunodeficiency due to family history of similar illness, likely phagocytosis defect. The final diagnosis was complicated fungal pneumonia. So we had decided to do more workup, as this patient is susceptible for primary immunodeficiency disease.
Shaima,
Yes.
please, 30 seconds.
Yes, okay. Lymphocyte marker, it came normal. Range immunoglobulin were normal. CH15 normal. So we sent oxidative burst test. The result came. The result came positive, confirming chronic granulomatous disease, as the normal range should be more than 98, and the patient result is 0.3. For the management, primary immunodeficiency genetic reported negative. Our explanation for that, it could be a novel mutation and need validation. So further genetics testing was sent to look for novel chronic granulomatous gene mutation. Patient responded well to steroid and antifungal and was sent to higher center for bone marrow transplant. Prophylactic antibiotic and antifungal were initiated, and the final diagnosis complicated Candida tropicalis pneumonia due to chronic granulomatous disease. For the conclusion, the underlying primary immunodeficiency disorder must be considered in any child with complicated pneumonia and inadequate response to the broad-spectrum antibiotic. In our case, the core was Candida tropicalis and is an interesting to isolate it from the lung of this patient, which considered as a novelty because normally considered as non-pathological colonization of the human plays an important role in elimination of pathogen. These are references. And finally, we bring discussion to the final, and I would like to thank our primary investigator, Dr. Ali Al-Suhail, and all the co-authors and pediatric pulmonary teams at Abha Maternity and Children's Hospital and King Fahd Medical City.
Thank you, Shaima. Thank you very much for this excellent presentation and well-prepared, actually, PowerPoint. Thank you so much, Shaima. And we would like to thank Dr. Ali for this actually great case to be shared in this research date. Any questions from the audience?
Assalamu alaikum wa rahmatullah. Thank you for this presentation. Can you let us say articulate again and explain clearly what is the unique about this case report?
We isolate Candida tropicalis from the lung of this patient, and this considered as a novelty because normally it's considered as a normal flora found in the mouth and in the bronchi. So it's not considered as causes of pneumonia. So this is a special of our case. And our patient is immunocompromised. So the message we want to deliver is you have to consider Candida tropicalis to be diagnosed or to put it in your mind. If you isolate it from the patient, consider as immunocompromised patient.
Thank you.
Maybe Dr. Ali has any adding?
Dr. Ali, please.
Thank you very much. The second message is this patient, he gave us a very hard time. We sent primary immunodeficiency panel for CGD gene mutations and available mutations, and we got the result negative. So we sent the whole exome sequencing. And hopefully we are still waiting for the result. And probably he has a novel mutation because we know CGD is X-linked disease. 95% of the time is X-linked disease. But his older sister died 5 years ago with the same problem. So if we find a novel mutation, we have to do for the whole family and the parents to identify if it's disease causing or not. So, and unfortunately, 5 days ago, I saw him. They brought his, a younger brother, he is 6 years old. He had the same problem, starting to have granulomas everywhere, no pneumonias, his lungs are okay, but probably he is going the same path. So the novelty is tropicalis, isolated from my lungs, and he responded to antifungal, and we gave steroid because he was dying. So the other novelty is the genetic, but hopefully in the next year we'll present it as a novel genetic mutations or something that's interesting. Thank you.
Thank you so much, Dr. Ali, for sharing this very interesting case. And it reflects actually how important to work as a team to reach such a difficult diagnosis. Thank you so much, Dr. Ali. Thank you, Shayma. Thank you so much.
Thank you so much.
Now, let me welcome our third presenter, Mohammed Saeed al-Nujaymi. He is last year medical student at King Khalid University. He will present a research entitled The Association Between Mode of Delivery and Developmental Dysplasia of Hip in Breech Infant. Mohammed, the mic is yours.
Assalamu alaikum warahmatullahi wabarakatuh. Good morning, everyone. My name is Mohammed Saeed al-Nujaymi. I will present to you our research, which is the association between mode of delivery and developmental dysplasia of the hip in the breech delivered children. The principal investigator is the Dr. Mahdi Al-Garni. I will start by the introduction about this topic. What is the DDH? DDH is a spectrum of condition in which the femoral head and the acetabulum doesn't form properly in the young children and the baby. It has different severity from patient to patient. It can be mild developmental instability, or acetabular dysplasia, or hip subluxation, or frank dislocation of the hip. Its incidence vary greatly according to the geographical location, which the highest rate in the Native Americans and Caucasians, and the lowest rate in the Africans. Its incidence is approximately between 0.1 to 6.6 cases per 1,000 live birth. Breech presentation, oligohydramnions, female sex, and prime parity all being happy to be risk factor to DDH. The aim of our research was to describe the DDH-related characteristics in the children born single breech and to investigate the risk factor associated with hip joint instability. Method and material. We used retrospective study among the 349 children who were admitted to the Abha Maternity and Children Hospital and Kamis Mashed Maternity and Children Hospital during the period from the 2015 to 2020 with DDH. Patient medical record in the two study hospital were retrieved and analyzed. Two authors extracted from the relevant data from the medical record and then were directly contact with the patient parent using a special data sheet. And after you finish the collect the data, we analyzed using statistical software, which is the IBM SPSS version 28. Result, this table number 1 demonstrates the personal characteristics of the children with developmental dysplasia. We found that the most children diagnosed with DDH were female, which the percent is the 77.7. And the age group most is between the 2 to 5 years, which equals 62.8%. And the birth weight is more between the 2.5 to 2.9 kilogram. And swaddling after the birth is equal 11.2%. Table number 1 demonstrates the personal characteristics of the mother of the children with DDH. more than half of the mother participant is between 25 to 35 years, and about half of the mother participant were consanguineous married, and about 2 to 5 of the mother participants are gravida. And gestational age, we found 78.5% of the mother participant is between 37 to 42 weeks, and almost most of the participant mother, they go to the antenatal care routinely. And about the mode of delivery, we found about 61.6 of the mother were delivered normally, and about 20.6% delivered by the emergency cesarean sections, and about 17.2 delivered by the planned cesarean sections. And 1/10 of the mother had oligohydramnions, and about 12.3% of the mother had gestational diabetes, and 1/3 of the mother had positive family history of the DDH. Table number 3. This table demonstrates the developmental hip dysplasia among the participant children. We found about 13.8%. We diagnosed them at the birth, and most of the children we diagnosed during the infancy period and after the first year. About the affected hip joint, we found 29.2%. The affected hip is the right side, and 31.2% the affected hip is the left, and 39.2% in the both sides. Figure number 1. This figure demonstrates the about 20.1% of the children had unstable joint, and about 79.9% had a stable joint. Table number 4. Children hip joint stability according to their characteristics. There is no much difference. There is no much difference between the significant according to the personal characteristics. Table number 5. Children hip stability according to their mother characteristics. The joint instability is increased with increase of the age of the mother, and also increase with the consanguineous marriage, and increase of the gestational age is less than 37 weeks, and increase the gravida, and also increase of had positive family history of the DDH, and also increase in the mother who had gestational diabetes, and also increase in the oligohydramnions. About the mode of delivery is increase with mother who delivered by the emergency cesarean sections. Conclusion. Developmental dysplasia of the hip is commonly encountered disorder among the infant in the Asir region. Saudi Arabia is mostly diagnosed during the infancy and mainly affecting the female children of the consanguineous parents. Hip joint instability is significantly higher among the children of the mother with high gravidity and those who had oligohydramnions. Screening of the newborn is highly recommended. This barcode for our references. You can take picture and read our references. And thank you for listening.
Thank you very much, Mohammed. Before I will open the floor for the discussion, I want to just comment on the tables. You have copy and paste the tables in the presentation without actually highlighting the important information you want to talk about. It was a bit distracting. We cannot actually pick up the information you are talking about. Next time, better to highlight the important information for the listeners. Thank you, Mohammed.
Thank you.
Questions, please?
Thank you for your kind, nice work. But there are some comments you should take care of in your conclusion. You mentioned that DDS is commonly encountered in Saudi Arabia, while your sample focused mainly on cases of DDS discovered, and you try to find their characteristic. So to reach that conclusion, it means that I understand from your statement that you screened for the disease, and then you tell me how many cases were found, the rate of that criteria. But on the other hand, you actually retrospectively looked for that disease. So a little bit you should elaborate more in modifying your conclusion, you see, just to be suitable for publication in a good journal.
Any questions from the audience? If no more questions, we would like to thank you again, Mohammed, for this great presentation, and we would like to wish you all the best. Thank you so much.
Thank you for all.
Our last speaker will be Ithar Abdurrahman Al-Muhsini. She is MBBS graduate from King Khalid University. She will speak or talk about the association between parvovirus B19 and thyroid or celiac autoantibodies among T1D and pediatric patients. Ithar, the mic is yours.
Is my voice clear now? Okay. Good morning, everyone. Thank you so much, Dr. Faisal, for providing me with a wonderful picture. Really highly appreciate. And thank you so much for your present. And I hope all the hopes to meet your expectation. Actually, one of the great team who worked hardly in this project, Dr. Ahmed Al-Hakimi, our supervisor, Dr. Ananda, and Dr. Harish, Dr. Ali Al-Asiri, Dr. Aid Shati as well. I hope to represent them with a good, inshallah, يعني, to meet their good expectation, inshallah. So actually, our presentation is about it's talk about the association between parvoviruses B19 and among patients with autoimmune disorder, such as celiac disease, thyroid disorder, and among patients with type 1 diabetes mellitus. And actually, I added 2 minutes awareness video about the type 1 diabetes mellitus, but in order to save our time, actually, I have to skip it to, and I will talk, inshallah, about it يعني, in coming few slides. So regarding type 1 diabetes mellitus, it is, unfortunately, till now, it is autoimmune disorder. And, you know, it is commonly found in young children and adolescents as well. Global estimations of annual pediatrics type 1 diabetes mellitus incidence growth rates 3 to 5%. And Saudi Arabia ranked 4th in whole world. And we have many autoimmune disorders such as celiac disease, adrenal insufficiency, vitiligo, as well as Addison disease. They have, or we have association, strong association with type 1 diabetes mellitus in one way or other. and more common with autoimmune thyroiditis and celiac disease. Also, we have a greater risk factor to developing autoimmune thyroiditis among diabetes 1, type 1 diabetes mellitus. Well, so regarding some study relieved that we have thyroid autoimmune disorders was 2-3-fold commonly found in patients with type 1 diabetes than healthy individuals, which means we have to be focused more in future studies. Among patients with type 1 diabetes mellitus, 50 to 80% have thyroid antibodies, and nearly about 50% known to develop clinical autoimmune thyroiditis compared to healthy individuals. And the prevalence of celiac disease among type 1 diabetes mellitus patient is about 4.4 to 11.1%. Studies suggest that raise an incidence of celiac disease autoantibodies among type 1 diabetes mellitus. I think it's better and important as well to do regular assessment and evaluation for patients with type 1 diabetes mellitus to exclude those antibodies for type 1, for thyroid disorders, autoimmunity, also the CD-related antibodies among those patients. So to summarize, and before summarizing, we have also some studies shows we have strong factors with viral infection, which is a significant factor association with thyroid disorders. So viruses is the most commonly observed environmental factor incidence autoimmunity to diabetes patients. But unfortunately, still we didn't have a substantial data that's regarding the prevalence of the association thyroid antibodies with also celiac disease-related antibodies and paraviruses B19 antibodies among type 1 diabetes mellitus to do research accordingly. So to include or to summarize our research, or sorry, our introduction, we have 2 points, 2 important points. Presence of autoantibodies among type 1 diabetes mellitus. The second thing is the B19 viruses has strong roles to triggering these autoantibodies. So this is our introduction. We will proceed to our aim and questions, research question. Does the infection, which means this is where our research comes in, does the infection of the viruses infection associated positively with coexistence of thyroid and celiac autoantibodies among patients with type 1 diabetes mellitus? And our aim to determine the association between the autoimmunity disorders and among patients with type 1 diabetes mellitus. Well, so regarding the material and methods, it was descriptive cross-sectional study. It was conducted over 1 year almost. The sample population was patients from 1 year to 18 years who have been diagnosed with type 1 diabetes mellitus, as well as who regularly visit to diabetes, Atir Diabetes Center. Totally was 174 children and adolescents who was diagnosed with type 1 diabetes mellitus, which is evaluated in our study. The samples were tested for the following antibody, autoantibodies for antithyroid peroxidase TBO and antithyroglobulin TG, as well as CD-associated related autoantibody, which is endomysium, which is EMA IgA, was detected also by using the primary smooth muscle slides using indirect immunofluorescence. Also, anti-tissue transglutaminase IgA was detected by indirect immunofluorescence. Also, the paraviruses B19 antibodies, such as through detecting antibodies, were quantified by indirect ELISA, such as IgG and IgM as well. Well, actually here we divided by demographic distribution of type 1 diabetes mellitus. We divided the patient samples to 4 groups.
قريب من المايك شوي.
Oh, sorry. Now it's fine? Very good. So we divided our patient samples to 4 groups. The majority here, when you look to the majority were adolescents with age group 10 to 18 years. And or the school age more than 5 and less than 10 years. The youngest age actually of our presentation was 1 year and 6 months. Based on gender distribution, actually, out of 174 of the patients evaluated, 93 of them, about 53.4% were females. So this is about the distribution for the samples of our presentation. Well, here is actually total number of our diabetes patients was 174, as we mentioned before. As a first step, actually, we screen them for autoantibodies of thyroid and celiac disease as well. So the prevalence of autoantibodies against thyroid, their number was 44. If you look here, we have a positive number of 44, which means about 25%, and also about the celiac disease positive number, 25 of them, which mean about 14.4%. And the next step was to detection of the pyroviruses among those antibodies for celiac and antithyroid autoantibodies as well. So it's also showed increase in numbers in thyroid disorder, which means the positive here is more than negative. That means we have a significant correlation or association between the autoantibodies among patients by enhancing or aggravating by B19 viruses. So the current results report the prevalence of antibody against thyroid and celiac disease showed a positive association with virus B19 seropositivity among children and teenagers with type 1 diabetes mellitus. Well, here actually, if you see the table, you will see the significant association between the presence of thyroid autoantibodies among and their seropositivity to B19 viruses with positive B value 0.04. And the outcomes show increase in the level of thyroid autoantibodies among the patients with B19 seropositive type 1 diabetes mellitus. And if you see here also, we have IgG more than IgM, which is, we have a significant association. So it's need actually to be explored in the future study to exclude the autoantibodies and the relation between the autoantibodies among patients with type 1 diabetes. Okay, here actually it's the related, the duration of the duration of type 1 diabetes mellitus among patients with positive autoantibodies. Here actually the results showed we have a significant correlation between the time and the prevalence of autoantibodies and the time duration. Yes.
1 minute. You have 1 minute.
Okay, sorry.
To conclude.
Okay, I will go fastly actually. So here is the prevalence. It showed actually we have a higher among patients with more than 3 years and similar associations in the studies elsewhere. The last one actually here is the prevalence association between the celiac disease among patients with type 1 diabetes mellitus. It is also showed a positivity about 10%, 0.9 for both EMA, which is antibodies among antibodies for celiac disease, which is celiac disease-related autoantibodies. So to conclude our talk, actually, this study observed an increase in prevalence of thyroid autoantibodies against seropositivity, B19 children with type 1 diabetes mellitus, and a positive association is found with increase in autoantibodies prevalence against thyroid disease. And when diabetes is advanced, which means if we diagnose patients when they're aged more than 3 years, and regular screening of type 1 diabetes mellitus patient, it is important to identify the B19 thyroid autoantibodies and antibodies and autoantibodies for thyroid and celiac disease also as well. And most importantly, further studies, it is required to establish the time of positivity B19 to detect and for the development of thyroid autoantibodies among patients with type 1 diabetes mellitus. I'm sorry to take longer time. Thank you so much for giving me the opportunity and chance to present this one. And I'm sorry actually for being too late. Thank you so much, by the way.
Thank you so much, Ethan, for this amazing presentation and good observation that parvovirus plays a role in vitiligo. Especially, this is my specialty. We know actually the autoimmunity to type 1 diabetes has good association with vitiligo since the 1977. We know that the association, and the parvovirus now B19 could be also tested in the future to be sure there is no association with vitiligo in the future.
Yes.
We should look after this. Thank you so much.
Anytime.
Any questions? Prof. Abdullah? Please give the mic to Professor Abdullah Shatur.
Thank you very much for this nice presentation.
Thank you.
My question was there a control group?
Sorry?
Control group.
I couldn't hear you well, actually.
Control group. Did you include, why did you include the control group in the study?
Actually, this study or this research, it is not a preliminary study. It is one of the serious research since have been started 2016. And actually, it is about the association between the type 1 diabetes mellitus and other autoantibodies. It's not only related to the autoantibodies as well. When they started since 2016, they started with coexistence and also the relation between the type 1 diabetes mellitus and other associations such as viral coexistence, cytotoxin, and etc. So I think I'm not sure if it's I can answer your question, but it's related to your
Well, I think a control group will make your study more informative and strong. This is my view.
Anytime. Thank you so much.
Thank you, Professor Abdullah Shatur. Actually, the aim of the study is to see the role of B19 virus and triggering of autoimmune coexistence of autoimmune thyroiditis among type 1 diabetes. So the control here is that, we need to study the effect of the virus or presence of virus on people with type 1 diabetes to see is it triggering the autoimmunity in those patients. So we have negative, if you see the table, we have negative autoantibodies and positive autoantibodies. These two. So we do need control in this case because we aim to study the effect of the virus among autoimmunity in type 1 diabetes. So we have negative group, type 1 diabetes, they have negative autoantibodies, and we have positive autoantibodies. Is it clear, huh? So the control is involved as because the study focused on triggering of autoimmunity among type 1 diabetes. Okay, I will say it again. Among type 1 diabetes patient, there is percentage of development of autoimmunity higher than normal population, and this is well known, okay? So those patients with type 1 diabetes, they have autoimmunity. Our question, what is the triggering of this autoimmunity? We screen and we found some group negative for those autoantibodies, associated autoantibodies among type 1 diabetes. Type 1 diabetes, and they have at the same time thyroid autoantibodies. We have another group, type 1 diabetes, they have no thyroid autoantibodies. We compare between them. So it's well controlled, Prof.
Thank you, Dr. Ahmed, for saving my life. Actually, he was our supervisor for this project. Thank you for your coming. واسمحوا لي قبل أن أنهي واحتراما للغتي العربية واللغة التي يحبها والدي كثيرا أن أشكر والدي على حضوري وتشريفه لي. أشعر بالامتنان جدا والفخر أن أقدم أمام والدي اليوم. أتمنى أن أكون عند حسن ظن دائما. شكرا لكم جميعا وأتمنى أن يكون يومكم جيد.
Shukran, Ithar. At the end of this session, we would like all the speakers for this great presentations, and we have now 10 minutes break before the last session.
باسم نادي الطب والإبداع نشكركم جميعا ونشكر عضو هيئة التدريس الدكتور فيصل الطبيقي على ما قدم. يتفضل رئيس الملتقى لتكريمه.
اعطني اشاره انك خلصت خلاص.
شكرا
الله يعطيك العافيه دكتور فيصل، شارك مقدم. الله يعطيك العافيه.
خدمتكم دائما.
الله يعطيك عساك تكون معنا دكتور ان شاء الله في الحفل.
اهم شيء لازم نقول
الله يعطيك العافيه. شكرا لك. الله يعطيك.